Good day, everybody. Welcome to the 2023 portion of the 2022-2023 UCLA Distinguished CTSI Speaker Series Award. My name is Keith Norris, and I'm the CTSI Senior Associate Director for Equity, Diversity, Inclusion, and Co-Director for the CTSI Community Engagement Research Program. I want to thank everyone who is joining us virtually and in person today, and ask everyone to hold their questions until the end of the presentation. It is my pleasure to introduce my colleague and good friend, Dr. Naina Harawa, who will launch this 2023 Health Equity Research Theme seminar within this series. Dr. Harawa is Professor of Medicine at UCLA with a dual appointment at Charles Drew University, where we both met over 15 years ago. She currently serves as the CTSI TL1 Training Program Director and Communicating PI for that program for this UCLA CTSI. She received her Bachelor of Science degree from Antioch University and both her master's and doctorate degrees in epidemiology across the street at the Fielding School of Public Health. During that time period, she also did pre-doctoral traineeships through the National Institute of Mental Health and National Institute of Allergy and Infectious Diseases with an emphasis on HIV and AIDS. Her research has been funded by the NIH, the CDC, and the California HIV/AIDS Research Program. Dr. Harawa has developed and tested several holistic interventions to promote HIV, STI, and substance abuse prevention, and linkages to services in underserved populations. Her work has included both qualitative and quantitative approaches, including novel randomized controlled trials, generally conducted in community settings with partnerships with the local health department, and using community partnered research approaches. These interventions have addressed the roles of culture, social and family support, homophobia, racism, substance abuse, and gender expectations in health risk behaviors and healthcare engagement. These efforts have established her as a national leader in community partnered research and how issues such as socioeconomic, substance abuse related, and contextual factors affect health service utilization patterns of sexual, gender, and racial ethnic minorities. Please give a warm UCLA welcome to Dr. Naina Harawa, who will present today on translational perspectives on pre-exposure prophylaxis for persons with HIV.
Good afternoon, everyone. Just pull up my slides. So I want to start by thanking the Health Equity and Social Science Research Theme for inviting me to be here today, and thanking Dr. Norris for that kind introduction and all of his support over the years. Can everyone hear me okay? I just want to make sure. Great, thank you. So my goal today is to tell you a translational story of pre-exposure prophylaxis for HIV, which is actually for prevention, so for people who may be at risk, to talk about what helped lead to the development of this highly effective intervention known as PrEP. But the PrEP story is really part of a much larger story about the HIV epidemic and some of those most affected by it. I will share parts of this story. It's not a short story, so I can certainly just share parts and describe how I hope future chapters of the story will be written through a translational science lens. I do want to share that in recent years, I've given a presentation and training for events co-sponsored by Gilead Sciences, but they were not about HIV treatment or PrEP, and I don't have other potential conflicts of interest. I also want to offer a note that most of my focus today is on the impact of the HIV/AIDS epidemic, especially on domestic, gay, bisexual, and other men who have sex with men communities, which we often shorten to MSM. But of course, HIV is a pandemic, and the HIV story is a global one. It most devastatingly impacted sub-Saharan Africa. And the US epidemic also particularly affects heterosexual Black cisgender women, in addition to transgender women and people who inject drugs of all races and ethnicities. So they are in no way not part of this story. So my story has 4 chapters. I want to first talk about how we got from inertia to rapid discoveries in the field of HIV prevention and treatment. Then to talk about how persistent and often growing disparities came to the fore over the course of some of these discoveries. I want to describe PrEP for HIV, both its promise and its reality in terms of the domestic fight against the HIV epidemic, and how we can use all of this information and all that we've learned today to move towards more equitable translation. So chapter 1, inertia to rapid discoveries. It's hard to, I think, for people today, younger people, it's probably hard to underestimate just how devastating early chapters of AIDS were. People were, thousands of people were dying, and much of that death, much of that illness, much of that grief was met by silence by the general community. But for the gay and bisexual community, this silence was not acceptable because so many people were being affected. And just to bring that statistic home, in 1995, it was estimated that by that time, 1 gay man in 9 had been diagnosed with AIDS in their lifetime. 1 in 15 had died of AIDS. And if you look just at the population of people ages 25 to 44 in 1995, 1 in 10 gay and bisexual men had actually died of AIDS. So we all know this term decimated, but its literal meaning is to kill off 10% or more of a population. And so for many of the gay men who are Gen Xers or baby boomers, the AIDS epidemic was literally decimating their peers, and often doing so in very visible ways, but the public and much of our government was doing very little in response. So in the midst of that devastation that was going on and what seemed to be inertia, people mobilized to take action. You can see here a picture of Larry Kramer and I love that this particular picture shows him in a by any means necessary shirt. Larry Kramer was the founder of ACT UP, and much of the mobilization came through ACT UP. And then you see on the left a picture of a demonstration by the Philadelphia chapter of ACT UP. And this was one of many demonstrations that brought home the level of grief and loss that was happening in the gay community, making it visible for many of those who did not yet seem to care. So ACT UP stands for the AIDS Coalition to Unleash the Power. And these dramatic and creative protests and acts of civil disobedience that they had were effective in garnering public attention, funding, and action. These actions led to changes in policies for drug approval, increased funding and attention, and greater engagement of both patients and communities and research processes, something that many people have advocated then and since, but was actually fairly rare at the time. But it's also important to recognize that despite my being able to find some pictures of people of color in ACT UP, and there were certainly people of color engaged, it was still largely a white gay male movement. And so many of the responses that came were most consistent with the needs of the people who were most able to mobilize at that time. One of the things I think is amazing that activism helped to put in place, it was, of course, there were many forces that helped to put this in place, but was a structure that really supports the entire spectrum of translational science. And for those who don't know, what I mean by that is that it was an infrastructure that helped support science going from the basic science and laboratory research all the way into patients and communities and community-based organizations. So that included research funding and infrastructure, including new agencies like the university-wide AIDS research program, now the CHRP, funding through NIH for centers like the Center for AIDS Research that we have here at UCLA and Charles Drew, that does a lot of more basic science and clinical research, or historically has done that. as well as P30 centers like CHIPS, which stands for Center for HIV Identification and Prevention and Treatment Services at UCLA, and CAPS that did more psychosocial and behavioral science. Another part of this translational infrastructure were research platforms and cohorts that allowed these more basic science discoveries to quickly be put into clinical trials and tested out on individuals, as well as cohorts of people both living with and at high risk of HIV that allow people to better understand the course of the natural course of HIV disease. These included the multi-center AIDS cohort study, the Women's Interagency HIV study, and then several different HIV trials networks, starting with the AIDS Clinical Trials Group, or ACTG. But all of that work would have only gotten so far if it wasn't for additional infrastructure that supported education and capacity building, so that those scientific discoveries were quickly getting to the providers and the community-based organizations that were serving the populations at risk for and living with HIV. As I said before, I can't share the entire story, but these are just examples of some of that those resources that were put in place for capacity building and education. The AIDS Education and Training Centers, we have one here at UCLA. The CDC put together a compendium of effective interventions. So as these were developed, it was relatively easy for other organizations to then adapt and put them in place. To this date, there's an excellent national HIV curriculum that you can access through University of Washington, just as examples. And then finally, and in some ways, for many patients and many of the people that I work with, in many ways, most importantly, is that there was infrastructure put in place for services so that as new availability for testing and treatments and prevention were coming to the fore, people actually could get that care. There were clinics that were able to provide that care, and there was financial assistance through things like the Ryan White HIV/AIDS program and the AIDS Drug Assistance Program to actually provide those services to individuals and cover those services. Furthermore, HIV helped set up a system in which services did not just happen within medical centers. There was HIV and HIV prevention that happened through outreach. There were new types of sites that were used for diagnosing people with HIV. You could get a test in a thrift store, a mobile unit, many different types of tests. The community was not just waiting for patients to come in and see them to find out about their status. And finally, undergirding this infrastructure since 2010 has been the National HIV/AIDS Strategy, which has been an effort led by the White House, but involves coordination at the federal level to help set priorities and strategize in a coordinated way how best to address the HIV epidemic. So I want to talk next about some of the scientific discoveries that this infrastructure helped put in place. But before I do that, I want to take just a moment to talk about the HIV life cycle, because it's important to this story. So here you can see the HIV life cycle simplified to 7 key steps. You have the binding of the HIV virus to cells. Here's a CD4 cell that has the appropriate receptors on the membrane. The virus then fuses with the membrane and kind of empties it, simplistically empties its contents out into the cytoplasm. And then those contents shuttle along the cytoplasm towards the nucleus. But in the process, HIV, which is an RNA virus, uses some of the cellular machinery to help convert its RNA to DNA. That DNA then enters the nucleus and is integrated into the human cell's DNA. And then it's set to be able to make new copies of virus that then get shuttled out back to the membrane of the cell, assembled. They eventually, those new viruses bud off from the membrane of the cell and mature so that then they are able to infect other cells. So this is important to some of the developments that I'll talk about in just a moment. So to think through some of the highlights in terms of HIV prevention and treatment science, especially as they relate to biomedical highlights, I've divided the first 40 years or so of the known AIDS epidemic and HIV epidemic into 5 different phases. In the first phase, between 1981 and 1985 is when those cases of AIDS were first discovered here in Los Angeles. The virus which caused those cases was identified. First tests for HIV were established and developed so you could diagnose somebody with HIV before they developed some of those more serious opportunistic infections. And routes of transmission were established because, of course, early on, people didn't necessarily know how transmission happened, which helped contribute to a lot of fear and stigma. It was in this next phase that we began to have therapeutics for HIV, many of these supported by the ACTG that I mentioned earlier, with the first of those treatments being AZT. AZT, or zidovudine, was a failed cancer drug that was then tested in people with AIDS and approved in just 4 months, in part because of those changes in policies that I talked about earlier. It was a specific type of drug that interrupted that 3rd stage of the viral life cycle, or reverse transcriptase, so that HIV could no longer translate its RNA into DNA and infect the cells. Other of these types of drugs, called NRTIs, or nucleoside reverse transcriptase inhibitors, were approved at this time. And it was also in this period that people started using post-exposure prophylaxis if there was an accidental exposure to a patient, to potentially infectious fluids of a patient living with HIV. So you can see that in this phase, we started to have treatments, but these treatments were still of limited effectiveness. While AZT did work, it quickly stopped working, in part because of evolution of resistance, and similar things happen with the other drugs, even when used in combination. So you can see here over this early period from 1985 till about 1994, the numbers or the rates of AIDS cases were still going up quite dramatically, and deaths were also still going up dramatically. This started to change in the next phase, 1994 to 2001. This is when perinatal HIV prevention was established, when they first identified a new class of HIV treatments, antiretroviral treatments called protease inhibitors. And then these were also followed by another set or another sort of type of reverse transcriptase inhibitors that work through a different mechanism. And these medications started to show much greater efficacy. I'll show that in the next slide. But I want to first talk a little bit about perinatal HIV prevention for a few reasons, but it really was a very important breakthrough, but that one that I think highlights both some of what is to come as well as the challenges of what was to come. So the Pediatric AIDS Clinical Trials Group 076 trial of perinatal prevention came out around the time that I entered this field. In fact, I see one of my colleagues from that period in the audience. And this was when it was first determined that you could actually prevent transmission of HIV from HIV-infected mothers to their infants. Prior to that trial, about 1 in 4 women transmitted HIV. In the trial, they treated mothers with AZT starting at week 14. They gave them infusions at delivery, and then they treated their infants to week 6. And in this group, they found that 8.3% of mothers transmitted HIV to their infants, in comparison to the placebo group or the control group that got placebo at all 3 of those points. And in that group, the infection rate was 25.5%. So of course, this was a game changer. The FDA very quickly approved AZT for use in this setting. And we are now at a point, as these protocols, et cetera, have improved, that very few perinatal transmissions occur in the US. Another bit of science that came out through that trial was the clear indication that the likelihood of transmission from a mother to her infant was strongly associated with the mother's viral load. So women with higher viral loads were more likely to transmit, lower viral loads less likely to transmit. This was one of the main factors that indicated whether or not transmission would occur. But as I said, there was also in this period new types of HIV drugs that worked on other parts of the life cycle. And it was here that you could see that those were making a difference at the population level. So beginning in the mid-1990s, you started to see the number of people moving to an AIDS diagnosis declining, and you started to see declines in the number of people dying of AIDS as well. In the next period, things got even much better, though, in terms of HIV treatment. While the drugs that I just talked about were effective, they still had this issue of emerging resistance. They often were hard to take. Sometimes it meant people had to take a dozen or more pills a day. And so this was very challenging for patients. Many people didn't adhere. Many people discontinued medications, or sometimes the medications just didn't work for them in the long run. By 2002, however, new drugs were identified that in combination were highly effective. Generally, people were taking 3 drug combinations, now called antiretroviral therapy. And there were new formulations that allowed people to take those 3 drugs in 1 or 2 pills a day. So it's a tremendous game changer, made it much easier for people living with HIV to adhere and stay on their medications, and often quickly brought down their viral load. It also became clear in this point what I already hinted at in the perinatal data, which is that there's a strong correlation between viral load and transmission established. So people started talking about, well, we need to treat people not just for their own health, but also to prevent ongoing transmission to others. And so if I just can go back to this slide for a minute, in the life cycle, and summarize kind of what's happened on the treatment front in this phase. As I talked about, if you think about these 7 different phases of the HIV viral life cycle, at first we had one drug, AZT, and a few other drugs like it that were NRTIs, nucleoside reverse transcriptase inhibitors, that stopped this step 3 of the viral life cycle. By the end of this last period, we had drugs that could also address binding, fusion, integration of the HIV DNA into the human DNA, and then assembly or budding from the cell. So together, these worked as a very powerful combination punch that kept people's viral load low, and often means people could remain undetectable for a long time. So now we're at kind of the last period, and it's in this last period that the first PrEP drug is actually approved by the FDA, that starting people and antiretroviral therapy become early, or as soon as they're diagnosed, becomes the standard. Previously, because of issues with resistance, difficulty taking medication, side effects, people were started at later stages of disease, but now we had medications that allow people to take it earlier, and the clear indication that HIV caused a serious impact on the immune system all along, so it was important to start earlier. Another key understanding that came out in this period was this idea of U equals U. So not only does lower viral load mean that there's a lower risk of transmission, we know now that once someone's viral load gets below a certain level of detection, they can no longer transmit HIV via sex. And so this idea of U equals U, or undetectable means untransmittable, I got that wrong in here, but undetectable means untransmittable was established, and is certainly something that has helped address HIV stigma among people living with HIV or having partners with HIV. Just go back one. So somehow I've gone the wrong direction. Okay. Sorry about that. So what is PrEP? As I said, this gets developed in 2010, but not approved till 2012. PrEP is an HIV prevention medicine that uses antiretroviral drugs to help prevent HIV when taken by people who are negative. It usually involves a combination of 2 medications as opposed to the 3 drugs that generally someone living with HIV would take. And it's now available in 2 different pill regimens, as well as an injectable regimen that I will talk about later. This is a little schematic about how PrEP works. In yellow and orange, you can see the drugs that are in a couple of the formulations of PrEP. Once they build up to sustainable or sufficient levels within the mucosa and within the cells that could be infected with HIV, they basically block that reverse transcriptase phase that I talked about earlier. So HIV can no longer infect those cells and make copies of itself. And it's been shown to be highly effective when people are adherent. So I spent a moment talking earlier about perinatal HIV transmission, because I think that it foreshadows many of the other advancements that I shared. It has been wildly effective. And when we look at the current protocols during pregnancy, it's designed to suppress viral load to, again, reduce transmission. During delivery, it's designed to do that, but can also act as PrEP or PEP for the infant. And then during the neonatal period, what I've shown here are the current regimens, and neonates, depending on the level of virus in their mother, may take 1 to 3 different HIV drugs, or given 1 to 3 different HIV drugs. And so at this phase, it can act as post-exposure prophylaxis or presumptive treatment. So I find it fascinating how much of what we now know and enact in terms of clinical practice about HIV were foreshadowed in perinatal HIV, prevention of perinatal HIV transmission. So I spent some time talking about sort of the course of HIV and prevention science, but I focused in on the biomedical science. Of course, there were many developments that happened at the policy and psychosocial levels. But over this last 15 years of HIV prevention, one of the trends that I've seen and that many of us have found troubling is there's been an increasing biomedical focus, in part because of these amazing treatments that we have, but also a decreasing psychosocial focus. And one of the challenges of that is that taking medication still has a psychosocial component to it. It has a structural and a policy component to it. In addition, there are some people for whom taking pharmaceuticals is just not the way they want to prevent something. And so it leaves those people out when we solely focus on the biomedical solutions. So kind of with that setup, I want to spend some time talking about disparities that unfortunately also accompanied many of the advancements that I just shared. So several studies, many different studies at this point, have found these troubling disparities when you compare white people to Black, Latino, and/or American Indian people. There are often lower rate or higher in whites. There are often higher rates of use of perinatal prevention, linkage to HIV care, use of antiretroviral treatment, retention in that treatment, adherence to that treatment, and non-occupational use of post-exposure prophylaxis. Unfortunately, in part because of those inequities in terms of access to these discoveries, we have these troubling trends. So here you can see data from looking at percentage of people diagnosed with AIDS between 1985 through 2017. Black people are in purple, whites are in orange or yellow, Hispanics are in teal. We can argue about the color names. But you can see over this period that there was really literally a flip in terms of the percentage of cases that occurred among Blacks and whites, with a large decline among whites and an increasing proportion among Black people, as well as a steady increase among Hispanic people. So much so that today, over 70% of new HIV cases occur among Black and Latino people. So I argue that all of this reflects this troubling pattern. We have activism, tremendous activism that leads to community mobilization and advocacy. This advocacy leads to increased patient and community engagement at many levels. It leads to funding, infrastructure, and policy change. These rapidly lead to discoveries and advances in both prevention and treatment. And of course, those lead to decreased morbidity and mortality. And that morbidity and mortality declines do benefit everyone, but they don't benefit everyone to the same degree. They also, unfortunately, because people are getting better, some of that attention, that urgency, that concern also goes down. So on the part of both people at most risk and the general public, there's this decreased attention and concern and increased disparities. Here's another view that to talk a little bit about those disparities and also the benefits that did affect all groups. But to give some numbers, here we're looking at changes in age-adjusted annual rates of death with HIV disease. And you can see in this period where those NN, RTIs, and the protease inhibitors first became available, and you have these declines in rates of death. The decline for whites was 76%, but for Black people, it was just 58%, and for American Indians, it was just 67%. So this is what I mean about the disparities, the inequities leading to disparities of outcomes. So we've been, as I said, a lot of my research is focused on the Black population, and there is now a large body of work that talks about some of the reasons for these disparities in various groups, with some of the structural barriers particularly or perhaps most deeply affecting Black communities. These include things like poverty and underemployment or unemployment, higher levels of uninsurance and underinsurance, higher levels and rates of incarceration, policing, police surveillance, and then finally concerns about mistreatment, both within the research and the medical realm. And this mistreatment relating to both current and past practices in which research subjects have been neglected, deceived, or mistreated, as well as people's experiences within the healthcare system or the experiences of their network members. And I want to point people to this report that came out last year from the California Healthcare Foundation, in which they reported that, again, this report came out just last year, that more than 1 in 4 Black Californians avoids care due to concerns that they will be treated unfairly or with disrespect. And that when you look at Black Californians who are LGBTQIA or have Medi-Cal, the percentages are 41% and 35%. So just the people who probably most need these types of services unfortunately, are sometimes avoiding it because of concerns about mistreatment. So moving on to PrEP. Unfortunately, PrEP, a tremendous advancement and a key part of our national HIV/AIDS strategy, presents yet another troubling example of this pattern. Just to share with you a little bit about the science first about PrEP and the importance of efficacy and adherence. PrEP was first determined effective in a 2010 trial called the IPREC study, but the efficacy in that trial was actually only 44%. And the reason it was only 44% is because only about half of the people allocated to the PrEP group were actually taking it. And when they looked specifically at people who were adherent based on detectable drug levels, they could see much higher levels of efficacy. And this was also confirmed in other studies of PrEP. So of course, like many other, almost every other medication, it doesn't work if you don't take it, or if you don't take it properly, or if you stop taking it. And what we're seeing in the US is that, unfortunately, a lot of people aren't taking it. So levels of uptake among groups most at risk remains below targets, and overall levels remain below targets. So the goal through the national strategy is that 50% of people at risk are using PrEP. The overall number we're at is about 25% per CDC, but for Black people, it's only 9% of those with indications for PrEP. For Hispanic people, it's only 16%. For whites, it's actually exceeding those goals of 66%. But you can see that this is a huge disparity. And we can add to it that levels of persistence on PrEP are actually also lower for Black people. I'm not as familiar with the data for Latino people, but there is this issue of not just uptake, but staying on the medication, even when people are prescribed. Now, Structural barriers are important and insurance is important, but it's certainly not the only issue. We studied that by looking specifically at Medi-Cal beneficiaries. PrEP has been available through Medi-Cal without prior authorization since the mid 2010s. And so these data are from 2019. And we looked at what they call PrEP to need ratios, which basically compare the numbers of people on PrEP to the numbers of new HIV cases in that group in the prior year. Higher ratios are better. And you can see here that the ratios for white and Asian females and males are 2 to 3 times the ratios for Black and Latino males and females. I don't want to make the assumption that, or I don't want you to think that race is the only disparity we see. There are also disparities in terms of PrEP uptake by region, by sex, and by age. Here's just the data for sex. There were 11 male PrEP users for every new HIV diagnosis among men, but for females, it was just 4 PrEP users for every new HIV diagnosis. So there's work to do at several levels. Through Charles University and CHIPS, we've been concerned about this issue and the potential for differential PrEP uptake for a while. We did interviews and meetings with local providers and people at CBOs to find out more. And we heard a number of things. Here I'm talking specifically about structural barriers. Cost was one of the issues that came up, especially at that point in time. For people who did not have Medi-Cal, the co-pays often made PrEP use prohibitive, even if their insurance covered it. Issues of healthcare access, challenges with identifying both willing and culturally sensitive providers. Several men who had sex with men either told us that they themselves or they had clients who reported not being offered PrEP by their providers or experiencing either denial or stigmatizing treatment when they requested PrEP. And then living situations can also be a challenge for individuals, especially if there's concerns about HIV stigma. So we know that there's high levels of homelessness in Black communities, as well as residential instability, which can make taking a daily medication difficult and can also mean that people have little privacy and may be concerned about taking a medication for HIV in that setting. So inequitable access to healthcare in Los Angeles is actually well documented, but I think many of us could live here and not necessarily think it's an issue. On the left, you can see a map that was put out by, the California Community, CHCC. I'll remember the reference, sorry. Anyway, they look at health professional shortage areas. You can see here in green and blue. And on the right, you can see by ZCTAs, which are basically zip codes, the majority ethno-racial group for different parts of the county, with Black people in dark brown and majority Latino areas in sort of peach, lighter brown. And you can see that within just a couple of exceptions, all of these shortage areas in terms of providers overlap with areas of our county that are predominantly Black or Latino. The other thing that we've seen in my research and that of others is this issue of risk perception, and oftentimes people's risk perception not matching reality. There's actually been a lot of research showing that Black men who have sex with men have higher risk of infection despite actually having similar or lower levels of risky behaviors. So it's natural that many of them may feel, well, I'm not particularly at risk. Why do I need to take this medication? So people might ask, well, why is there differences in actual disease risk if the behavioral risk doesn't differ? There's a few explanations of this. They include the fact that there's lower levels of HIV diagnosis and uptake of treatment, and therefore viral suppression among people's sexual partners. There are sexual network factors that are more likely to mix together higher and lower risk individuals, as well as higher levels of untreated sexually transmitted infections that then can make people more susceptible to transmitting or acquiring HIV. Another thing that was raised in our work, Another thing that came up in our work and that we heard was that the guidelines were often confusing. And you could see this, I think this is less of an issue now that the CDC and the US Preventive Task Force have simplified their guidelines and made them actually a lot broader. But early on, for probably a host of different reasons, you could go to one provider and that clinic would have one criteria for offering PrEP. Another clinic might have a different criteria. The county criteria sometimes differed from the CDC criteria. So of course, this created a lot of inconsistency and ambiguity for individuals. And then the last issue that I want to talk about is just differences of norms, values, preferences, and then issues with stigma. I think we often kind of assume that part of the problem is a lack, but I think some of it also just has to do with preferences and norms. For some people, preventive care is not a norm, and I would argue that this is particularly true for men in their 20s and 30s who often have little reason to see a medical provider unless they're injured in an accident. In fact, Davis found in 2014 that Black adult men, just 40% lacked a usual source of care. I think about my brother who proudly told me at age 30, it was the first time he'd seen a doctor since he'd become an adult. And so, we're asking people to engage in preventive care in an ongoing way who may not be sort of set up to do so. Preventive care is also kind of a middle-class concept. If you work in an hourly wage or you grew up with a family who didn't have insurance, the idea of going and paying to see a provider or losing that hourly wage to see a doctor when you're not sick is kind of it can be a very strange idea. Issues of stigma and biphobia, racialized biphobia are also a major issue, homophobia. If one's concerned about disclosure of their sexuality or hears negative things about their sexuality within their community, that may dissuade them from disclosing their HIV risk or acknowledging it in a way that makes them consider PrEP. And then finally, preference for non-pharmaceutical methods. And I would love to see more research done in this area, but both from research, but also just my experience in Black communities is there's a lot of avoidance of medication. I think a lot of people don't want to take medications. We have lots of reasons where we later hear medication is bad for you. You watch TV and you're told, well, you can sue because you took this medication and now you have cancer. And there's any number of reasons that people may want to avoid a pharmaceutical intervention when they're not sick. And part of why I argue that last point is because when we look at non-pharmaceutical interventions for HIV, we actually tend to see similar or higher rates of uptake of these interventions among Black, Latino, and American Indian people than whites. This includes things like HIV testing, condom use, and harm reduction practices for injection drug use. In the interest of time, I can only show you one of these, but these are data on the right, on your right or your left, you're right, from 2017, and they show rates of HIV testing or basically what percentage of people had ever been tested for HIV, what percentage have been tested in the last 12 months or never tested. And you can see that for whites, the percentage ever tested was just 42%. Whereas for Black people, it was close to 70%. And for Latino people, it was still somewhat low, but higher than for whites at about 49%. So how do we take all of this information and move toward more equitable translation? Part of what I argue is that we know that this pattern is there, so that we need to anticipate and address it earlier in the processes of translational science. Specifically related to PrEP, some of the recommendations from the literature and the local providers, and local providers include the importance of client-centered care coordination, having both targeted and general PrEP educational campaigns, the targeted ones ensuring that the people who need to see it and realize that PrEP might be for them, but the general ones, A, catching other people, but B, also helping to address stigma and not just make it seem like PrEP is just for this one group of people who are extremely risky, for example. We need to expand pathways to PrEP, just as we've expanded pathways to HIV testing. There should be more pathways into PrEP in order to facilitate both knowledge and acquisition of PrEP. And then it's really important that there are also wraparound services to support both PrEP adherence and persistence, which is also a challenge. But I think we always have to think, all of those recommendations I think are excellent, but it's really important we always keep in mind the root causes, that if we want to improve health equity, we have to get to the root causes of inequities. And that includes building an infrastructure that actually supports health equity, making it a strategic priority, partnering with community, both in our scientific efforts, but in these larger efforts, and eliminating racism and other forms of oppression. I want to just, well, not quite close, but give an example of some work that we've been doing that tries to do some of this. We have an ongoing study called the Mobile Enhanced Prevention Support Study, and it's designed to test the effectiveness of an intervention in improving engagement in PrEP, regular screening for HIV and STIs, linkage to and retention and treatment for SUDs, and reducing recidivism. The reason we're working to reduce recidivism is we're specifically focusing on individuals who are post-incarcerated, another group of people who have very high levels of HIV risk, and we're focusing in on transgender women and cisgender men who have sex with men. The intervention itself, which was formed and in many ways initiated by our community partner, Los Angeles Centers for Alcohol and Drug Abuse, as well as by our Community Advisory Board and prior pilot RCT work that you can see referenced at the bottom, includes client-centered holistic wellness planning and referrals. And through this, we try to address not just people's healthcare-related issues, but other issues that might be related to more general social determinants of health in order to help provide more greater stability and a sense that they can then prioritize their own preventive health. We also provide for the intervention group incentives for engaging in services, a self-selected peer mentor who has lived experiences, who works with them and provides encouragement and support, and a mobile app that's designed to support the other components of the intervention. So we have enrolled over 200 people and randomized them to the intervention and control groups. I can only share preliminary findings because the study is ongoing, but among the 158 people that we have so far with at least one follow-up intervention, we're really pleased to say we've seen much higher levels of PrEP uptake, more than twice, close to 3 times the levels of PrEP uptake in our intervention versus our control group. We also see evidence of increased uptake of HIV and STI testing. Unfortunately, we're not seeing differences with either recidivism or substance use, but the people we've recruited are all in substance use treatment or some kind of a substance use intervention when we start. And so they're all getting better. Thankfully, they're all reporting declines, but these are similar for both of the groups. The last piece of research I just want to mention is that we've now, in the last couple of years, moved to long-acting injectables, which have been approved for both HIV treatment and prevention. And in this reference below that I think I will move on from, but we provide some suggestions that help to suggest ways to ensure that there's both successful and equitable rollout of these most recent scientific advances. So I just want to close before questions and call out NCATS, the National Center for Advancing Translational Science, because they've recently prioritized diversity, equity, inclusion, and accessibility, pointing out that addressing racial and ethnic health disparities and inequities that persist in screening, diagnosis, treatment, and outcomes is central to their mission to deliver more interventions to all people more quickly. They talk about the importance of a comprehensive perspective that views the translational science through this lens at all stages and identifying potential roadblocks across these stages of research, as well as diseases and conditions. And then they list here 3 focus areas for this work. And I would just encourage that for NCATS and for all agencies, we also keep this last piece in mind, which again goes back to these root causes that inequities in society and our systems of healthcare delivery stifle translation. And so we can do what we do in our realm, and that's important, but we also have to continue to call this out and advocate for greater equity in terms of root causes. So I realize I'm running low on time, so I'll just conclude and say that despite it being a rapidly emerging and fatal infectious disease that was killing many people, HIV biomedical research only rapidly accelerated because of activism that led to changes in policies and increased engagement of groups in research as well as funding. In other words, while emerging infections or outbreaks can fuel translation, these conditions can still be ignored when they impact marginalized groups. So by margins, I mean the people at the sort of the edges of society, who the way most things are done are not necessarily tailored for, and they often have to work hard to get to the center. My next point, throughout the pandemic, increased disparities have accompanied scientific advances in treatment and prevention, but these partial successes have also been accompanied by decreased levels of concern and attention. And so translation should be framed as an issue of justice and equity. And then finally, current research would benefit from cross-disciplinary collaborations, effective community and patient engagement, human-centered design approaches, technologies that are specifically developed to maximize acceptability and ease of use for those at highest risk of infection and poor virologic suppression. And finally, implementation strategies should prioritize those providers who serve them. In other words, translation should center those on the margins. And with that, I will conclude. I have pictures of just some of my collaborators from the papers and stuff that I highlighted that are part of the work that I've done. And I also want to give a shout out to my current study teams and community partners. And with that, I would be happy to take questions.
Let's start with any questions of the audience here, and we'll sort of alternate between in person and online.
Comments?
Answers.
Hello. So in the presentation, you showed a map showing the LA area. So I was born and raised in was in a city that's majority Black communities, Latino communities. And before I learned about a lot of the health disparities, I learned about these cultural barriers that prevented me from accessing medication. So how is that being addressed in a lot of these longitudinal studies? Basically facing the fact that you have to unlearn this, which is a big part of our culture, to learn something that's going to benefit us long term.
So your question is, how do we address some of the cultural barriers that lead people to be less likely to access care? That's a great question. So part of why we have the peer mentors in our interventions is really that you have people with often of similar demographics and similar lived experiences who are then helping work with individuals and talk about, okay, yes, I had those same reservations, or I was raised in the same way too, but this is why I decided to do something different. I don't think that's the only answer, but I do think it's part of it. Some of the work that's been done with, for example, with church leaders in both Black and Latino communities to help sort of bring this talk of health into another realm and frame it in a way that's not just about your doctors telling you to do something, but the importance of doing it for respecting your body tempo or for your family. I think we need to like tap into what are the norms and what's important for various communities, and then use sort of that language and those approaches to help encourage that. I think I'll leave that in interest of time, but great question.
One question from the virtual audience. What would you say is the reason for white people having greater access to healthcare, but not getting tested for HIV, and yet showing lower rates of acquiring HIV?
Yes, great question. So you asked, I think people should be able to hear you. I think that in part is because white people correctly believe that they have lower risk for HIV. And there's two things that are happening at the same time. If you didn't catch it, there may be higher rates of testing among Black people, but there's also still higher rates of undiagnosis. So the one is not been enough to make up for the other. But I would say that that's probably the main reason. But the other is that providers often don't offer HIV testing. And unfortunately, there are white people who suffer from that as well. I remember just recently we were at a meeting in which a white woman talked about how she, was very disappointed. She was never been offered HIV testing. She'd never been offered PrEP. She was diagnosed somewhat late in her disease, but no provider had ever made these things available to her. So sort of that idea of the general messaging and the targeted, I think is really important, because there are people across groups, both in terms of demographics and behavioral risk groups, who are at risk, and all of us, if we're sexually active, for example, should have been tested at least once, and many of us repeatedly.
Another question, where do we go from here? And is the scientific community inclined to pursue biomedical solutions over more simple preventive methods?
I mean, we're scientists, and I totally respect the desire to sort of continue to push that edge of discovery. So I think, yes, the scientific community is inclined to do that, because if you're a biologist or a virologist, that's kind of what you do. I don't disregard that or want to denigrate that. But in terms of resources and a nation, how it is that we should put our resources, I would argue that much more resources need to go into these simpler solutions and ensuring that people are able to access the many, many discoveries we already have and where we still don't see sufficient access.
And another question is, what is the status on vaccines for HIV? Where do we stand? How's it looking? Do you know anything more about it?
Yeah, unfortunately, I don't study the vaccine world, and so I'm not the best person to ask that question. I know we still do not have a vaccine. I know that there's been some hope because of the mRNA technologies that have been developed in terms of new strategies, but we do not yet have a vaccine. Oh, they've been... We want the audience to hear you.
Thanks for the talk. My question is, you presented the history of the past 40 years of the HIV epidemic, and also nearly the 10 years of PrEP implementation, and recently the outbreak of monkeypox or mpox also disproportionately impact the GBMSM community, especially among those racial and ethnic minorities. So I just wonder, from your perspective, what are the lessons that we learned from the HIV epidemic and PrEP implementation should be considered, or we should try to avoid to further exacerbate the health disparities among racial and ethnic minority GBMSM? Thank you.
So I think a lot of the sort of solutions that I put forth are not limited to HIV, and I'm glad to see that NCATS is now also prioritizing it. The paper that I referenced, I believe, is still a preprint, but it should be coming out. One thing I want to point out is that, which is an incomplete answer to your question, but that some of that infrastructure that was developed that helped get HIV testing and treatments, et cetera, to people was marshaled for COVID and for mpox. And so, for example, and vice versa. So for example, the ACTG infrastructure was used to launch COVID clinical trials and be able to put a lot of that in place quickly, much of it under the leadership of Dr. Judith Currier, who was here. In addition, when they were doing some of the monkeypox efforts, in some cases, they were also offering HIV testing and STI testing, and vice versa. They were going to sites where a lot of gay and bisexual men were getting that kind of testing or those services and offering monkeypox. So I think that that's also really important. Unfortunately, stigma continues. And so the extent to which people can go to one place and get multiple services has a particular benefit. But yes, I guess I think I've answered your question, but there's probably a lot more to be said. I also want to make one other point about monkeypox, and I don't have extensive data on this, but I've been struck. A couple of the providers that I know have said that they had patients who were refusing a COVID vaccine, like lining up to get a monkeypox vaccine. And their perception in part was about the patients were worried about stigma and they were worried about the rash. And so, early on, that's how AIDS was. People sometimes had a rash, they had visible wasting. There were these things that unfortunately marked people with the condition. And that also sparked some of that urgency and the sense of let's do anything to avoid it. PrEP came out when people were already living for a long time, amazingly healthy lives with HIV. So I think it's a little hard to get that same kind of urgency among the people who most need it. But these patients, like, my colleagues were saying, like, I don't want that, please get me something, right away, because they had that same fear about something that could physically sort of in a way mark them.
Well, let's give Dr. Harawa.